Hello and welcome everyone. So my name's Dr. Matt Clark and I'm a clinician scientist and consultant pediatric neuropathologist. And I'm also the college's undergraduate and foundation lead. This involves leading and coordinating the college's undergraduate and foundation activities with the aim of increasing awareness of the pathology specialties and inspiring the next generation of pathologists and clinical scientists. I'll be handing over to our webinar host, Zainab, very shortly, but I would just like to start by introducing you to the Royal College of Pathologists and giving you a little bit of background about the college. So first of all, we are a professional membership organisation and have charitable status, and we have over 12,000 members who are mainly pathologists and scientists who are working across 17 different pathology specialties. We also have undergraduate members and foundation fellows, so do get in touch with us if you would like to find out more about this. Most of our members work in hospitals and universities in the UK, although we also have international members working and training in a wide range of countries. And we also oversee training, exams, professional standards across the pathology specialties as well. So I'm really delighted to welcome you to this careers webinar on red cell haematology this evening. And I'm going to hand over to Zainab, who's going to introduce our speakers.
Hi everyone, I'm Zainab. I'm a fifth year medical student, and I've been supporting the college in running this series of careers webinars for the past couple of years. And I'm really delighted that today we have two guest speakers who can tell us all about what a career in red cell hematology looks like. And Dr. Emma Drasar is a hematology consultant at the Whittington Hospital and University College Hospitals, London. Dr. Chloe Merrion is a senior haematology specialty registrar in the final stages of her training in North Central London. And our panel will speak for about 40 minutes, and after that we'll have a Q&A in which they'll answer your questions. So if you have any questions for our speakers, please put them in the Q&A box. So over to you, Emma.
Thank you very much. So just to get going, just tell you a bit about my career pathway. So I trained at Barts in the London, in East London, and I qualified in 2001. So it all makes me feel rather ancient. I then did as was then house jobs and then the equivalent of core medical training or IMT in East London and South London before starting my haematology training back in South East London. So I just sort of halfway through my 5-year registrar training, I took time out. Number one, to have my daughter Beatrice, who was 17 yesterday. And having taken 6 months maternity leave, I then undertook a PhD with Professor Thane, who now runs the sickle cell research unit at the National Institute of Health in the US, looking at the markers of severity and predictors of organ dysfunction in sickle cell disorder. Finally finished work part-time for a bit after that, for a year, and then completed my training and got my consultant post 10 years ago. I've also, as well as a research interest, I've also got a management and sort of process interest, and I'm the network lead for our region for sickle cell and thalassemia and rare inherited anemias. So my pathway's been varied, is what I'd say. One of the nice things about haematology training, in my opinion, is its flexibility, be that working part-time or in different roles, and it can change with you. There's the 5-year registrar training, but there are increasing number of CSER or non-standard routes into becoming a red cell hematologist. My top tip is that the system will try and push you into a specific pathway because it's more convenient for the system. But actually, as long as you get there in the end, I went to medical school aged 18 and I was the consultant before I was 40. And that was even with having 3.5 years out to do my PhD, working part-time, and having a child. So it's not fastest to the finish. You can, and I'll probably still be working for 30 years as a consultant. So there is flexibility, and don't let anyone tell you there isn't. Chloe.
Thanks very much, Emma. So I am Chloe. Thank you very much for having me. I'm a haematology reg. So for those of you who know about kind of medical training, haematology training's 5 years, and I'm nearly at the end of it, ST6, but I've taken an out of program and I'm doing a PhD with Dr. Emma as my supervisor. Looking at aging and inflammation with our collaborators at the London Metropolitan University. And I started in a bit of a different way. I started medicine a bit later. So I went to Nottingham and did an undergrad biology degree. And then I decided like medicine was for me. So went to the University of Warwick and did the 4-year graduate entry medicine course, and then moved to London and have done my training in London. And I've done all my heme training in North Central London, so that's how I've met Emma. And now I'm taking a few years out to try and complete this PhD. So yeah, that's me. And now we'll tell you more about red cell hematology and why it's the best specialty. So just to quickly kind of explain this side. So what are red cell disorders? So there's loads of different types of red cell disorders. And actually part of being a hematologist is being on the pathology side as well as the clinical side. So looking at blood films, looking at bone marrow aspirates, all that sort of thing. And I think red cell morphology is really fun and it's really cool. And you can make a diagnosis just by looking at someone's blood sample with a few other kind of simple, easy tests. So on the left-hand side, as you can see here, these are sickle cells. So sickle cell disorder is a massive part of being a red cell hematologist. In the middle, this is a patient who has thalassemia, lots of different red blood cells. These little dots with the dense nuclei are nucleated red blood cells. And then on the right, less commonly, we come across things called membranopathies. So this is just a random example of someone who's got a condition called hereditary elliptocytosis. But by far our biggest bulk of work is looking after patients with sickle cell disorder and thalassemia. And we'll explain a bit more about that in the next few slides, so you can get a feel of what we kind of do and the sort of patients we look after. But just to highlight why it's important and why we're here today to kind of say how great a specialty it is, they are a bunch of conditions, particularly sickle cell and thalassemia, that are often poorly understood, and that leads to a lack of education and poor patient outcomes. And on the right, you can see this picture of No One's Listening. This was kind of an inquiry looking into the avoidable deaths of patients with sickle cell disorder, and this came off the back of a young gentleman who was left in A&E and unfortunately died from sickle cell complications that could have been prevented if he was listened to and if people knew more and took the condition more seriously. And he was 22 years old, and that breaks my heart because that's not an uncommon story, unfortunately. And the lack of understanding and the lack of attention it's received is a large part of it is due to institutional racism. These disorders primarily impact kind of patients of Black and other ethnic minorities. And I don't think it's got the attention it has deserved over the years. And like I've mentioned, like poor Evan Smith and other patients, it's led to premature deaths in this patient population. I'm saying it's a rare disease, but actually sickle cell disorder is the most common and fastest growing genetic condition in the UK. So even if I don't manage to persuade you or Dr. Emma, which I'll be surprised at because she's very persuasive, not to do red cell hematology today, you still need to really know about sickle cell disorder and thalassemia because you will come across it in your career, particularly if you work in London, but also all over the UK now because, the population is growing. So what is sickle cell disorder? So sorry if I'm kind of, teaching you to suck eggs, but just to quickly go over it. So it's a genetic condition which is recessive. So you need the gene from your father and the gene from your mother. And it's all to do with inheriting this hemoglobin variant called hemoglobin S. And what this does, unlike normal hemoglobin, when it releases its oxygen to tissues, it's vulnerable to becoming polymerized. So it sticks together, and it makes and all the hemoglobin does that in the red blood cell, and then it deforms the red blood cells. So they become very fragile. So it's broken down easily, but it makes this sickle shape, as you can see here on the right hand of my screen. And this gets blocked in blood vessels, and it gets blocked in organs. So major organs like the brain and the lungs and the liver. But also what it does is it gets blocked very easily in the bones. And when you get widespread sickling, more of this blockages happen. And this results in severe pain. And, our ladies who have sickle cell disorder compared to, say the pain from these blockages in the bones, which are called vaso-occlusive crises, is worse than things like childbirth. So that's a comparison about how severe the pain is. But this doesn't also happen in the bones. It can happen in the lungs and the brain, like I've said, and this can lead to acute organ impairment, so stroke. So sickle cell disorder is the most common cause of childhood stroke. And in the lungs, it can lead to kind of widespread damage that leads to kind of a very rapid deterioration, and that's called the acute chest syndrome. So you've got a massive mix of a chronic anemia with the impact of what anemia does to the body, and then also these acute complications. And these patients live not knowing when this widespread sickling can happen. It can happen randomly, or, it can be triggered off, but with things like the cold, emotional stress, infections. Fortunately, and it's a very difficult disorder to live with, because if people don't understand that you need strong painkillers to get out of pain, sadly some people have dismissed these patients and said they're kind of opiate seeking, which is not the case. They're in severe pain. And obviously we all know that people interpret and manifest pain differently, yet sadly that some patients have been dismissed because it's not what they don't look like, they're in pain, etc. And it's just to also say that the most common type of inheritance where you get a sickling disorder is when you inherit the hemoglobin S, so this variant that causes this polymerization, from your mother, and S from your father. But you can also get it if you inherit S and another hemoglobin variant. So there's lots and lots of hemoglobin variants in the world, like tons. But getting like a mutation in a beta thal type mutation or something called hemoglobin S can also result in a sickling condition. And sometimes they're dismissed as not being as severe as the traditional HBSS, which is also a misconception. So sadly, the disorder is kind of full of misconceptions, and has a long history of being dismissed, and that makes it kind of difficult for patients to manage, because it's they're very wary, some patients, of healthcare because of their experiences. And this slide just kind of shows some of the complications you can get. So the yellow boxes are these acute complications. So because this sickling and this widespread sickling can happen anywhere in the body, you can get a wide range of manifestations. So I think what's great about red cell hematology is you have to kind of be aware of the whole body. So you're kind of like, you need to be good at general medicine to kind of understand, how things are going wrong and how you manage them. So some of the most common things are, like I've said, the acute chest syndrome, where you get sickling in the lungs. But patients are also immune suppressed because sickling happens in the spleen, which is a large organ that helps to coordinate our immune response. and patients typically get infarcts in their spleen, and then their spleen doesn't work properly, so they're very vulnerable to getting infections. And actually one of the most meaningful drugs that has changed the face of sickle cell over the years is penicillin. Just giving prophylactic penicillin to our patients has meant that patients do not die in childhood from septicemia, essentially. And we'll show you a nice slide next about kind of how it's changed. So yeah, I could labor this point for ages, but I don't want to keep going. I don't want to run over time. But this just shows how, you know, how this is a multi-system disorder, and you kind of have to be aware of all the potential complications. And because you look after patients throughout their lifetime, it's not just these complications that patients can get, they can get other medical problems on top of this. So you do have to be quite dynamic in your thinking and your differential diagnosis, which I find really fun. I love general medicine, and I think it's very rewarding to, you know lots about different parts of the body and how things are managed and stuff, because you work with lots of different people because of all these complications. So for instance, because our patients are vulnerable to gallstones, we know lots about hepatobiliary complications, so gallstone complications, and we work with surgeons. Because patients get damage to their joints, we work with orthopedic surgeons a lot. Because of the damage to the heart, we work with cardiologists. So that's very rewarding, because we truly work as a multidisciplinary team, or hopefully we should do anyway. And this just highlights some of the treatments for sickle cell and what has happened to the life expectancy. So as you can see here, as I mentioned, one of the most important interventions in sickle cell happened in the 70s, and you can see penicillin prophylaxis just pushed up the life expectancy of our patients and patients across the world. So although I'm talking with a UK focus on sickle cell, actually the majority of patients are within the malarial belt, and the majority of patients are in Africa, and where malaria is prevalent, because this is how the mutation has spread, because it confers a population level resistance to malaria. So the introduction of penicillin, and then a drug called hydroxycarbamide, which was initially a chemotherapy drug, but then we found that it had an impact in ameliorating sickle cell disorder for multiple reasons, including increasing the level of fetal hemoglobin in a patient's body, which helps dilate out all the kind of hemoglobin S, so to stop the polymerization, as it were. And then starting to transfuse patients who were at risk of stroke. So we do childhood screening for patients with sickle cell disorder, HBSS, to make sure that the children, as their brains are developing, are not getting damage to their major blood vessels, which we know is a big risk factor for getting a childhood stroke. So screening for that and introducing transfusions has massively helped with that. And as you can see here, like, the UK data shows that patients are now living into their 60s and 70s, which also comes with a whole other challenge that we haven't yet conquered, basically, because we're living in kind of this real-time data now. So that's sickle cell disorder. I could go on about it for ages, but I will move on and introduce thalassemia, and Emma's going to talk about that.
Thanks very much, Chloe. So unlike sickle cell disorder, which is a qualitative problem, so patients have plenty of hemoglobin, but it's a variant type. In thalassemia, it's a quantitative problem where they don't produce enough hemoglobin. So sickle cell disorders usually characterized as a single gene disorder. As Chloe's demonstrated, that's actually not true in its presentations. There's as many presentations of sickle cell as there are patients with sickle cell. Thalassemia is very diverse in its mutations, which can affect either the beta or the alpha chains of the hemoglobin. Again, it's a recessive inheritance, and a lot of patients have a combo of different mutations, and it results in a chronic anemia. So that can either be severe, i.e. patients can be transfusion dependent, so they need transfusions from infancy to sustain life, but they can also be non-transfusion dependent. But the potential complications are different from each of the different types, but are still potentially significant. Next slide, please. So again, we've got here a survival curve. So as you can see, prior to 1960, patients fundamentally died of chronic anemia. So this is mainly focusing on this data on the left is for transfusion-dependent patients. So children would be born, they'd fail to thrive, and then unfortunately they'd die. And unfortunately, this still occurs in areas of the world where there's not good access to safe transfusion therapy. So in the 1960s, we started transfusing these patients, so their survival improved, but unfortunately, with each unit of blood comes iron, and that iron is deposited in the organs of the body, so particularly the heart, liver, pancreas, pituitary, and that had significant impact. Patients were then dying in either late childhood, young adulthood of arrhythmias and cardiac failure. However, the development of chelation treatment, so that's drugs that remove iron from the body, has then led to massively improved survival. Like with all medications, they don't work in the box, okay? So patients have to take them for them to work, but certainly the options are out there. With the non-transfusion dependent patients, they can get lots of the issues that we think potentially more that you'd expect more with people living with sickle cell disorder. So their non-transfusion dependent thalassemia is basically a chronic hemolytic anemia. So these patients can get cerebral ischemia, like my sickle cell patients. They can get pulmonary hypertension and right-sided heart complications. They can still load iron even when they're not transfused because of the bone marrow working extra hard to make red blood cells. That increases iron absorption from the gut, and so it can the body can overcompensate. Gallstones, their spleens can get big. They can get what we call extramedullary hematopoiesis. That's where you get the body's trying so hard to produce blood cells that it's trying to do it all around, not just in the bone marrow, but in the spleen, paravertebral space, etc., etc. And they're more prone to clots as well. So as Chloe said, with sickle cell disorder, exactly the same with thalassemia. It's a lifelong complex multi-system condition. We really are going into the unknown with the thalassemia patients. So I look after the oldest thalassemia patient in the UK. He's 67, true transfusion dependent patient. And no one else, nowhere in the world has anyone looked after a patient who's 67 with transfusion dependent thalassemia. So it's really a privilege to look after these people. It's a privilege to really feel like you are pushing the boundaries of science and progress in not only just keeping these people alive, but also trying to maximize their quality of life. Next slide.
And this is just to highlight that sickle cell and thalassemia is the bulk of our work, but in clinic, you'll come across lots of other things to do with red cell disorders. So other rarer inherited disorders known as rare inherited anemia, A condition called diamond black fan anemia, the congenital dyserythropoietic anemias. And on the left-hand side, you can see an example of diamond black fan anemia. So there's, other rarer anemias we look after, the membranopathies. So I showed you this blood film at the start of the talk. So this is where you get kind of a chronic hemolytic, so increased red cell breakdown. So we keep an eye on these patients. Patients who have genetic mutations that mean that the enzymes that help the red cell work and help the red cell lifespan last 120 days. We look after patients with those. We also look after patients who have, I've said there's loads of hemoglobin variants out there, like literally loads. There's a hemoglobin that was discovered in Wigan, for example, called hemoglobin Wigan. I've not seen it myself, but there's tons of hemoglobin variants that can result in a lifelong chronic anemia. So we see those patients in our clinic as well. And patients who've got disorders that lead to increased iron, because we know from thalassemia with the transfusions, like Emma was saying, that iron accumulates in the body and we have no way as humans to get rid of the iron, so we have to use kind of tablets and things or just gradually over time use up the iron stores. So we look after patients with other disorders of iron overload, because iron accumulates in organs, which is bad. And that includes genetic hemochromatosis, but also patients who've had lots of transfusions for other reasons. So our colleagues who look after patients with hematological malignancies, they require a lot of blood to get them through, a bone marrow transplant, for instance. Sometimes we'll advise on how to get rid of the excess iron, because they could have had up to, 20, 30, 40 units of blood. So, although it's red cell disorders, there's lots of things that we look after. But my favorite and the bulk of our work is sickle cell and thalassemia. So, yeah. And I'm just going to hand over to Emma, because to be a red cell disorder, to be an expert in red cell disorders, you also need to know about blood transfusion, and that's a whole science within itself.
Yeah, so one of the great things about being a haematologist is, as we've sort of banged on about, is the lab and the clinical. So if you're someone that likes science, likes a bit of practical skills, but also likes patients, it's sort of the career for you. And one of the nice things about being a red cell haematologist is understanding transfusion science and transfusion medicine to a good level, so that you can sound sort of super impressive and clever. So unsurprisingly, we use transfusions a lot in our practice, but we also have people who, for religious or personal reasons, do not want transfusions. So we advise on that situation as well. And we also have patients for whom have limited options with regard to what blood is available for them. And one of the reasons, particularly in our red cell patients, is that because life originated in the continent of Africa, that's where the greatest genetic diversity is. And that genetic diversity is then reflected on the proteins that are expressed on the surface of the red blood cells. So, and in contrast, the majority of blood donors are white. So there's been a lot of work by some of my patients actually have been involved with this, around encouraging donors from different backgrounds to donate blood. In the middle there, that picture is my parents' red cell phenotype. When they were doing their PhDs at Mary's in the 60s, they were next door to Prof. Mollison's lab, and he was responsible for the discovery of many of the red cell antigens that we're aware of today. And if any of you have ever worked in a lab, or especially a research lab, you will know that one of your Your duties being in the lab is to basically give test samples and act as a control. So that's nothing new under the sun. That was going back in the 60s as well. Next slide.
And the importance of research. So I think if you're into research and you like research, haematology is a really good specialty to get into, because not just red cell pathology, but all kind of haematology pathologies are driven by quite cutting edge research. And I'm really lucky to have trained at like University College London, where there's lots of clinical trials. But going back to red cell and why red cell research is super important, well, actually, this was the first condition that was diagnosed. These conditions were first diagnosed using genetics, and now we're using genetics for diagnosis of loads of things, including cancer diagnostics and all that sort of thing. So sickle cell was at the forefront, and then suddenly there was 2 treatments available, 3 treatments if you include penicillin, this hydroxycarbamide I've mentioned, which was initially a chemotherapy tablet, and transfusions. And then there was nothing for a very long time. And we have to ask ourselves, why is that? And I think, part of the reason, and, it is the fact that these disorders, the majority impacts is in, the majority of patients are in Africa. So we looked away. The majority of patients are Black and other ethnic minorities, and institutional racism has its impact there. But now things are looking up again, but there is still challenges. So I've started a PhD, as I've mentioned, and we've really struggled to get research funding, for instance. So, we're kind of doing it on the cheap. And it's quite disheartening to, quote all these facts, about how, if you look at another monogenic genetic disorder such as cystic fibrosis, the research funding for that, the research funding for another genetic disorder that comes within haematology, which is haemophilia, are much more funded for research, and much more, there's much more, per patient research funding that goes into those disorders versus sickle cell. There's the lack of research in the country compared to other disorders. So, it's a struggle, but things are looking up. Again, sickle cell and thalassemia are now again at the forefront. We have gene therapy that has been approved on the NHS, where we're using this very kind of cutting edge gene editing technology called CRISPR-Cas9, and we are referring patients, which at the moment the early data is showing this is potentially a curative therapy. So this will ameliorate, by editing the genes, this will ameliorate the effects of the sickle hemoglobin or the thalassemia, so patients don't have to be transfusion dependent and don't have to necessarily worry about vaso-occlusive crises and life-threatening crises, particularly, as winter comes and all the other triggers that make sickle such an unpredictable condition. So things are looking up, but again, this is a very expensive technology that's not for everyone, and there needs to be more tablets and needs to be more research into how we can ameliorate some of the impacts of sickle cell, particularly in our older population, where this newer therapy is just too toxic for these patients. And sadly, although I'm saying things are looking up, 2 drugs in the last 5 years have been marketed as a new treatment for sickle cell and then taken away from these patients. So the mistrust and how disheartening that must be for these patients, I can't emphasize enough. So yeah, research is really important into this condition. And although we've got gene therapy, which is fantastic and it's super exciting, it's not the magic bullet yet. So there's still lots to be done. And my focus of research and Dr. Emma's is kind of how are we looking after our older patients, because we don't know what happens. We're in an era where patients are living longer because of the treatments we have and the knowledge we have because of research, but we don't know what's going to happen, how we set up frameworks to look after our patients. So that's some of our research work which is focused on. So it's a great specialty to get into if you are interested in why do these things happen, why is it so unpredictable, because these are questions we still don't know. So there's a lot of broad topics you can do, and I think what I found really great is it's not just lab-based science that it can be done with red cell disorders and other disorders of, like thalassemia and other chronic disorders. It's, I've learned a bit about qualitative research, and I'm hoping to do a bit about that in my PhD and things. So you could become a really varied researcher and learn lots of skills, and there's lots of things to be done. And then there's all the transfusion research as well that will have a massive impact on this patient population. So over to Emma, because I feel like I've spoken enough. Why did you choose a career in red cell disorders?
So I chose a career in red cell disorders for sort of a variety of different reasons. So partly from an upbringing perspective. So my father's from what was then Czechoslovakia, and my paternal grandfather and the family had to leave Czechoslovakia after the Second World War, and my grandfather was actually a refugee in Europe and spent quite a lot of time in refugee camps before he made it to join the rest of the family in the UK. My dad was Professor of Bacteriology at the London School of Hygiene and Tropical Medicine, and the number of students and colleagues that that I met through him, basically for my entire, as long as I can remember, people from Sudan, my uncle Cyril from Bangladesh. I had, Auntie Balkis from Saudi Arabia. People from all around the world would be sort of in my parents' sitting room eating sort of vol au vents and like having a cherry or other beverage. And even people from areas of the world where there was active conflict occurring were sort of brought together. And that led me to have like a fascination and an interest in conditions that were prevalent in the UK, but also have a more sort of international focus as well. I was lucky, and I chose to do haematology because I've always liked the lab. And then I was fortunate enough to to be exposed to some brilliant haematology consultants who really inspired me and showed me how rewarding red cell haematology was. Next slide. As I said earlier, I love the balance, I love the lab, I love the clinical, I love the research, and also management options as well. So you can really have the best of all worlds in red cell disorders. But most importantly of all, my patients, they are an inspiration to me on a personal level, looking at them, seeing them as people in their environment, thinking about them as whole people, not just sort of organs floating around in a miasma. These are real people with lives and challenging situations, but also high level jobs. I've got high court judges, I've got doctors, solicitors, and I've also got, stay-at-home ladies and dads who are just doing their best to bring up their kids in a challenging world. Scientifically, red cell disorders are very interesting. And also, I love a fight. I do like trying to improve people's social and political and other situations. But I think, you know, what we want to avoid and what I always feel being mindful of is, you know, I'm not these, you know, trying to avoid the whole white savior complex narrative, because what you should be is a good ally, and you should support people in achieving their potential, not patronize them. Over to you, Chloe.
So why did I choose a career in red cell disorders? Well, I think first and foremost, this is an email that Emma sent me in 2021, so in September. So I was a month into haematology training, and I've cut out a bit of the email because it contains confidential information. But she sent me this email to say that you should definitely consider a career in red cell. So I think the importance of having a mentor in medicine is like, I can't even overstate it enough. Like, Emma's an amazing mentor, not just to me, but loads of people. She won an award at UCLH last year, so congrats to that. And I can't tell you how many people nominated her, but having a mentor who you can discuss your fears with, your aspirations, and someone who will help you and guide you is so important. And she showed me the way quite early on, and I haven't really looked back, to be honest. I've done 5 years nearly of training, and I still really love this this kind of subspecialty of haematology. So yeah, there was a sense of injustice after I kind of started working within red cell. It was my first job, and just seeing how patients were dismissed, asking why there are such limited treatments, why, you know, why can we not predict complications better, that sort of thing, why are patients living with a sword above their head, not realizing why didn't I know much about this in medical school. Like, this is quite a massive condition, and it's awful. And just seeing the tragic outcomes that have come about through my training in London, this was before I even started haematology, it's heartbreaking. And yeah, you have to avoid the white savior complex. I don't view myself as someone who's going to tell a patient what to do. They've lived with this their whole life. I'm just there to like bounce them, like give some like medical advice, you know, talk to them. And it's really like, you know, just listen to them and see how you can make the treatments work within the context of that patient's life. Like Emma mentioned something about tablets don't work well if they're just in the box. So it's about finding out, like, why aren't patients taking tablets? Why don't they want to take tablets? And it's like such a privilege to go through milestones in life. So I think what's amazing is, you know, we see our patients through pregnancy, we see patients through, you know, university, and all that kind of that those life milestones that we go through as well. So you can, you know, although I have a very different experience and probably arguably much more privileged because of the color of my skin, and, you know, being able to get into medical school and all that sort of thing, just working with patients, seeing their experience is such, you know, and listening to them is such a privilege. And, you know, like, I love clinic because it's so nice just to catch up with people who you do generate quite a good relationship with, and it's really lovely. And there's a good combination of the outpatient care where you can sit in clinic and catch up with patients, and then inpatient, which can be quite stressful at times but very interesting. Patients come in acutely, and you can do something like a red cell exchange, which is a treatment where you exchange all the blood of a patient with kind of blood that doesn't contain sickle hemoglobin, and you can see them get much quicker, so fast. And, you know, knowing that and having to have a good knowledge of transfusion and how the lab works makes the hospital a really interesting place to work. And the opportunities, like I said, there's loads of research that needs to be done, there's loads of educating that needs to be done. So if you think you're interested in teaching or research alongside your medical career, like, it's a great opportunity to get in and make a difference. And Emma mentioned management. I don't think that's something that's taught very well as we grow up through our medical careers, but like, managing a service makes a huge difference and makes a huge impact on patients. So what Emma's done with the red cell network has meant that patient safety and these patients get better care as a result of her, even though she's not directly seeing all the patients, you know, in this big area. So I think it's really cool, basically. But a good mentor makes a massive difference. So, hopefully in the future, as I grow up and stuff, I will hopefully mentor people like Emma's done for me, because honestly, she's changed my life.
Yeah. Thank you, Emma and Chloe, for that lovely talk. It was very insightful. And we've already got a couple of questions, but if you haven't had a chance to, you can still put it in the Q&A box and we'll just go through them one by one. So the first question is, are haematologists needed in most countries of the world, or would you struggle to get work in some places after specialising?
You're needed everywhere.
Everywhere.
You do the lab, you run the transfusion service. So even if you don't want to be patient facing, like, a transfusion consultant might choose not to be so patient facing, but they still have to know, like, and be there to give advice. So, you're needed everywhere.
Everywhere in the world does a full blood count.
Big time. And a blood film, probably.
And a blood film. So yeah, I'd say everywhere in the world. And I've had colleagues that I did my specialist training with who were born abroad, came to the UK for their training, and have now set up some amazing services in the Sudan, in Kenya, all over the world. People working in the States, people working in Australia. Some of the best centres are in India, Pakistan, Middle East. The world's your oyster, really.
Thanks. And then the next question is, I'm looking towards a career as a clinical scientist, and I wanted to know if you had any idea of what the day-to-day work would be for that position, or even a consultant clinical scientist position. How does it differ from your job roles? So I think this is like someone that studied a science degree instead of a medical degree.
Yeah. So that I've examined the PhDs of clinical scientists, consultants. So you definitely will end up taking some form of sort of research qualification in your area of specific interest. The ones I know tend to all work in specific sub areas such as transfusion and or diagnostics such as hemoglobinopathy diagnostics. And that can also extend into more of a like molecular role where you can setting up sort of high throughput PCRs, etc. So I think with what I would say, the colleagues and friends that I've had in that area, it's been very much about them staying up to date with research, trying to stay ahead of that research curve so that new diagnostic options are brought into clinical practice early. Good collaboration with university and research colleagues, academics helps like bring that in as well. And so I think that's attending specialist MDTs, giving specialist advice, particularly thinking of our national panel. Often it's the consultant scientists who are giving advice on what units of blood are available for patients with complex transfusion needs, etc.
Great. And then our next question is, what advice would you give to students or early career clinicians who want to specialise in haematology?
Chloe?
So, I mean, obviously, I think we've made the talk quite political as it is, but I do like feel for juniors. It's hard to get into. It seems ridiculous how hard it is to get into IMT and what you need to do these days and things like that. But start thinking about, if you want to do haematology, what I did was, I think I did a couple of posters when I was like junior. But I really focused on just being like trying to learn to be a doctor. I don't know if we can, like, maybe I've kind of grew up in the time where you could just focus on doing your job and trying to like learn and do that stuff. But I got my exams out of the way. I pursued my interest. I have an interest in teaching, so I did a teaching fellow year. I got reached out to a few haematologists and worked on some audits that I presented at BSH and that sort of thing. I don't think you need to do everything all at once, but trying to show an interest in the specialty early. So, even going to clinics and stuff and being like, what can I do? And, you never know, that consultant may have some audit or even research project that you could work on. I think doing research these days is very hard. Like, it's very hard to get a publication. So trying to do things like a poster or something, go to conferences and learning more. But I think like just trying to, you have to do your broad-based medical training. So you have to do like F1, F2, IMT, to just trying to, get through that and like take in, you do need your general medical schools if you want to do hematology. So like just trying to take that in and stuff. And I hope, places for training will become better and more flexible, because it seems really tough at the moment. I am sorry for those, early career doctors who are on the call, because it seems a lot tougher than when I was training. But I think like I just kind of kept a steady, constant kind of interest in the specialty, and presented a couple of posters at BSH, and then pursued what else I was interested in, which was teaching at the time. I knew I always wanted to do research, but it's quite hard to be like, go to a consultant and say, give me a research project, because research takes a while, and that's what I've learned. So don't beat yourself up if you haven't got 20 publications in BSA, BJ Heme, or ASH or something. Like, just try and go to the conferences, go to clinic, and like get a feel for it.
Yeah, and I'd say it's consistency. So it's showing sort of a consistent, like a level thinking, doing some fellow posts. I can tell you now, there are always haematology fellow posts, and you can do them either after F2. I've had people do them after F2. I've had people do them after IMT. I did 2 fellow posts and what used to be called a locum appointment for service, so a locum junior reg post, before I got my number. So it's, do bash out an audit, perhaps a poster, and you should be fine in haematology. We're not cardiothoracics.
And then a sort of similar question is, what advice would you give to someone who wants to get into this field with a biomedical science background?
I'd think about, I'd attend, see if you can attend any in-person conferences or meetings. There's I can share, there's the hemoglobin sort of society. We have regular meetings, and it's good just to go along, talk to some people over lunch or a coffee, because the thing about red cell hematology is that we're far less how can I put it, competitive, if you know what I mean. We're not sort of perhaps we're very friendly, and we're just pleased to meet someone else who's interested in our area. We're very collaborative, let's put it that way, as a subspecialty.
And then someone's asking, do you need to have a medical degree?
So to be a hematologist in the UK, you do need to have a medical degree, but to be a hematologist, but you can still be if you've got a science background or a nursing background, or indeed a, pharmacy. I've got a specialist pharmacist. So there's always roles that people can, subspecialize into, from whatever background they're from.
And I just want to add, I think there's quite a bit of information about this on the RC-Path website as well. There's a careers section and the different routes you can take for the different pathology subspecialties, including hematology.
Yeah, you
So
can
that
see a
might be
terrible
useful.
you can see a terrible video of me from 10 years ago. Wearing a
And then,
lab coat for authenticity.
is there scope for regenerative medicine, such as stem cell therapy, in managing and treating haematology disorders and diseases?
Yeah, so stem cell transplant in red cell disorders has been around for 20 years. And as Chloe was saying, there's the gene therapy use of stem cells is now coming in. It will be interesting from a regenerative point of view, particularly with the significant amount of bony damage that occurs in people with sickle cell disorder and with thalassemia. I think that's going to be an interesting area for sure.
And then, how do you see gene therapy and gene editing shaping the future of treatment for sickle cell and thalassemia?
So, currently it costs £1 million a pop. Okay, so it's £1 million per patient at least, and the current it's several things. So one, it's getting the stem cells out of the patient so that you can send them off to gene editing. With sickle cell, that can sometimes be quite challenging because of the scarring that occurs in the bone marrow due to the sickling that occurs there too. You then have to have access to specific laboratory facilities so that the gene therapy, so that processing can be carried out. Then the patient has to be fit enough to withstand what we call standard conditioning. So that's very high dose busulfan to basically wipe out their own bone marrow and immune system to make room for the genetically altered bone marrow. That has impacts on fertility. There's risks of liver dysfunction. People have to have a decent level of renal function, etc., etc. And because of the cost and facilities required, it's really limited to in access at the moment. So I think, yes, it's got potential. There's a lot of work being done on chemo-free conditioning. So I think it's an area to watch.
And then just last couple of questions because we're almost at time. So, what's a typical day in the life of a hematologist? How long do you normally spend in clinic and the lab?
So my office is in the lab. I'm there quite a bit. And that's quite nice because then I can just wander around to check on my laboratory staff and see if they've got any queries, etc. So I'll spend time on the ward round. So if I'm on call, I'll do the ward round. Usually pop up into the wards like daily. I do 3 clinics a week. So that's half day clinics. We also cover the day units as well. So we've got at the Whittington, we've got a specific red cell day unit, which we also cover. I get emails and contacts for advice from patients, other clinicians, and we also get a lot of queries when we're on call at the Whit from general practitioners and review all the referrals as well. So I'd say it's probably about 70% direct clinical care, 20% lab, but that's my choice, if you know what I mean. I could do more lab. And then sort of admin and management for the rest.
Thank you. And then just the last question. What's the most exciting part of your job and what's the least exciting?
Chloe, do you want to?
The patients are the best part of the job, like 100%. Like, I really love my patients. It's exciting to work with them. Like celebrating their life wins, being there for their losses, and that's not just looking after their disorder. It's like you're with them for their life. And I guess like the frustrating thing for me at the moment doing research is like sometimes it can feel a bit slow and a bit bureaucratic, and the lack of funding and the losses that like you're really passionate about something and you apply for a grant, it takes you ages, and then they're like, no, So yeah, that's my most frustrating thing at the moment.
Great, thank you both. I'm going to hand back over to Matt now.
Thanks very much. And just a huge thank you to Emma and Chloe for such a fantastic webinar. That was really, thank you so much for your insights, honesty, and I've learned a lot from it, and I'm sure everybody's really enjoyed it. So thank you so much for your time this evening. Thank you very much to Zainab as well for the excellent sharing, to all of you for your fantastic set of questions as well, and also to Penny and Demelza who are working behind the scenes to support the development of these webinars as well. We're going to send you a short feedback survey by email, so please share your thoughts about the event via that as well. And also, this is one of a number of different webinars that we've hosted, and you can watch the previous careers webinars on YouTube channel. And we will also add the recording of this event to the playlist as well. Also, each year we run 2 essay competitions, one for foundation doctors and one for undergraduates. And this year's essay questions center around pathology tests and their impact on patients. And the 2026 competitions are now open, and you can find out more information about these and how you can enter on the website. And finally, you can also find out more about pathology on our website, but also on the YouTube channel and Instagram as well. So thank you so much again for joining us. I hope you enjoy the rest of your evening. And thank you so much again to Chloe and Emma and to Zainab for the fantastic webinar. Thank you.
Thanks very much.
Thank you. Bye.